Welcome to Substance Use Disorders and Acquired Brain Injuries with Dr. Tracey Meyers.
Thank you. I'm excited to be here today to talk about this important topic. I am a licensed clinical psychologist and neuropsychologist with over 25 years in the fields of brain injury and recovery. And so today we'll be talking about substance use disorders and the intersection with traumatic brain injuries. I'll be describing a case at the end, putting all the concepts together in terms of treatment and challenges. So we'll start by talking about the definitions of substance use disorders and brain injury, how to assess substance use disorders, the prevalence, and some of the information around why people use, the principles of addiction and the reward centers of the brain. And then specifically looking at the intersection between substance use disorder and brain injury, recovery considerations, and finally a case review. I want to give a shout out to the Brain Injury Association of America for some of the slides today and some of the important work they're doing to share critical information about brain injury. So acquired brain injuries are a group of diagnoses around conditions that relate to the injury to the brain that are not hereditary, congenital, or degenerative, or induced by birth trauma. And they occur after birth with presumed normal brain development preceding the injury. And as a result of an acquired brain injury, there are changes in the neuronal activity affecting the physical integrity, metabolic activity, or the functional ability of the nerve cells in the brain to communicate effectively. And as a result, the brain may have different strengths and weaknesses after the acquired brain injury due to the changes in the neuronal activity. Acquired brain injuries are an umbrella definition because it includes both external and internal insults to the brain. External forces may be when the brain is struck by an object or with a fall hitting the floor, for example. An internal insult to the brain may be something like lack of oxygen or a bleed in the brain. Traumatic brain injury, it is a subset of an acquired brain injury. It's an alteration in brain functioning due to an external force. And it can be either a closed injury, where a head is struck by an object, or it can be an open penetrating injury, like a bullet wound, for example. Now we're going to talk about substance use definitions. First, we'll start with substance misuse, which is the consumption of alcohol and illegal drugs, and the use of prescription drugs exceeding the prescribed amount or use of another person's prescription drugs. So misusing substances that weren't prescribed in the way they were intended. A substance use disorder, which we're going to talk about ongoing in this presentation today, including the Diagnostical and Statistic Manual, DSM-5, talks about how a substance use disorder is continued use of a substance despite the health, psychological, or social consequences. Hazardous use, using the substance in a way that represents a public health concern because there's higher risk of physical, mental, or social consequences. Psychoactive substance misuse is using a psychoactive drug, for example, a hallucinogen for non-medical purposes. And finally, high-risk drinking, the use of alcohol to be considered unhealthy for most of the US population. So the substance use disorder, here's our DSM definition, lists several criteria, and you don't have to have all of these symptoms to qualify for a substance use disorder. In fact, the DSM defines mild, moderate, or severe based on how many symptoms one has. So mild may only be having 2 or 3 of these symptoms, where moderate or severe, anywhere from 4 to 5 for moderate and 6 or more for severe. So let's take a look at these, as these are really important to understanding what a SUD is. So A, taking the substance in larger amounts or for longer than you're meant to. B, wanting to cut down or stop using the substance, but not managing to. C, spending a lot of time getting, using, or recovering from the use of the substance. D, cravings and urges to use the substance. E, not managing to do what you should do at work or at home or at school because of substance use. F, continuing to use even when it causes problems in relationships. G, giving up important social, occupational, or recreational activities and using the substances again and again, even when it puts you in danger. Continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse. Needing more of the substance to get the effect you want, what we call tolerance. And finally, the development of withdrawal symptoms, which can be relieved only or most commonly by taking more of the substance. So looking at these, and not only how many, but how they change over time. These are the specific substance-related addictive disorders: alcohol, cannabis, hallucinogens, cocaine, inhalants, opioids, stimulants, sedatives, caffeine, and tobacco. And then new in the DSM-5, gambling and virtual addictions. DSM-5 came out in 2013 and included these two. So how do we know if someone has a substance misuse disorder? So we want to focus on assessments that can provide a lot of helpful information. Many people recognize that they might have some problem drinking or problem use, but they may not consider it to be a substance use disorder. So I find it very helpful to invite people to take screening assessments to see where their use falls. That's really the beginning stages of recovery, to be able to accurately and honestly assess one's use. So we can use standardized assessment tools. They're typically self-report questionnaires, very simple. They can range from only a few questions to a comprehensive screening. So these are a couple of them I'm going to show you now. And CAGE is one example. It's very simple. You can just see the simple questions. And although we wouldn't diagnose alone based on a standardized assessment like the CAGE, it gives us an indication that this is an area that needs further exploration. And people can be often surprised when they meet the criteria. They may say, oh, well, everyone around me drinks this much. I had no idea that this actually is a substance use disorder. Here's a couple of other examples. Look at the CRAFT, the ASSIST. And you can see it just helps people to begin to look at the level of severity of use, how often they're using, how much it affects their daily life, right? Because people become very accustomed to using and may not even pause and reflect on, oh yeah, people keep telling me I should be cutting down, or how often I'm actually using substances by myself, for example. These are all indicators of a substance use disorder. So prevalence of substance use disorders, and the research is really pretty striking when we think about the prevalence. Substance use disorders cause approximately $740 billion a year in expenditures. And this includes lost productivity if people aren't able to work, crime, healthcare expenses, including inpatient, outpatient substance use treatment, incarceration, etc. About 19.3 million Americans battle substance use disorder. About 75% of that group are using alcohol. Another 38% are using other substances. And then we have a combined alcohol and substance use about 2.5 million. So these numbers are staggering. And then if we add in mental health issues, we're adding another really important group in. So we have about 19 million people that have mental illness, and then the subsection of folks that have both mental illness and substance use. About 3.7% of the population, or almost 10 million people, have both substance use disorder and mental health issues, what we would call a dual diagnosis. And so when we're thinking about treatment, it's going to be really important to include both substance use disorder and addiction ideas and supports, along with treatment for mental illnesses like depression, anxiety. And then we add in brain injury, which we're going to be talking about in the second half of this webinar today. We're talking about really important fundamental recovery principles that we need to include. So why do people use drugs? So it is a multifaceted issue, right? If it were so simple as to only be one thing, we would have more effective and better treatments. But because we have these multifaceted challenges to look at, it becomes harder and harder to treat it. In a way, it's like a moving target, depending on who you're working with and their unique genetic, social, developmental, cultural, and personal coping skills vulnerabilities. So first, genetic vulnerability, having a family history of addiction places individuals at a higher risk. Social environment, things like peer influences, parental views towards substances. Early use can make a big impact, particularly for the developing teenage brain. Cultural attitudes. Use of alcohol in different cultures varies widely from, drinking age to when it's introduced at the dinner table, right? Or not introduced at all, depending on where someone lives. And then individual vulnerabilities around using substances to cope with painful emotions, mental health issues, trauma, right? So we want to have a compassionate, holistic view when we think about substance use. Edgar Allan Poe writes this, pretty distressing example of why he uses. He says, "I have absolutely no pleasure in the stimulants in which I sometimes so madly indulge. It has not been in the pursuit of pleasure that I have periled life and reputation and reason. It has been the desperate attempt to escape from torturing memories, from a sense of insupportable loneliness and a dread of some strange impending doom." So you can see trauma, you can see mental health embedded in here, right? And the devastation and the insight that there's been devastation around the use of substances. So again, that compassionate view that many people are using substances and are not getting any pleasure from it. In fact, it's become this way of trying to escape. So addiction. So the National Institute of Drug Abuse talks about addiction as a chronic relapsing disorder characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes in the brain. And that's really what we're talking about with addiction. We're talking about how the brain changes with repeated use. Sometimes addiction, or the term addiction, can have a stigma attached to it. The DSM-5, in fact, stopped using addiction as part of its definition because of the stigma. And using the term substance use disorder was one of the ways that they tried to decrease the stigma around it. But if we think about addiction from a brain perspective, it can be very helpful in understanding why it's so challenging for people to recover from substance use issues. And this really is around what happens to the brain with repeated use. So stages of addiction, we have first use, how an individual learns to use drugs and how it makes them feel. Then continued use, using it more frequently, which takes more and more time. And then tolerance, and this is one of those early signs of kind of a true substance use issue, right? More use of a substance to get the same desired effect. Dependence, where a person has physical symptoms of withdrawal and only can be essentially cured when they have more of that substance. So the brain is now actually dependent on the substances. It's needing the substance to regulate. And finally, addiction, a person's using despite the negative consequences. So the effect of the drugs in the reward circuit of the brain are one of the most challenging things to overcome when someone has a substance use disorder. Essentially, initially, in the early stages of substance use, the brain creates a sense of euphoria. And this we've seen happen with the opioids, why opioid dependence has become such a public interest crisis, because it doesn't take long for these drugs that target the brain pleasure center to essentially rewire and change how the brain responds, right? So when the brain is flooded with excess dopamine, it changes how the brain takes in and its natural reward center, right? It changes how the brain perceives pain. It changes how the brain perceives normal, natural rewarding activities like food, music, and sex. So we see how the prefrontal cortex is involved with motivation in seeking and desiring a substance, how the pleasure centers of the brain are impacted when there's use of dopamine flooding into the system, how the brain remembers that reinforcing or rewarding feeling, how the emotion center of the brain is now impacted by the use, and then it creates this ongoing, very difficult to break cycle of wanting and needing more to feel okay. We can see how negative emotions or situations can also trigger use. And for people that have chronic stress or chronic mental health issues, substances typically involve a decrease in some of the emotional pain, like Edgar Allan Poe was suggesting, and that can lead to cravings and ongoing compulsive use. And the cycles are difficult and painful, as you can see. So what are treatment options? So I'm going to talk about treatment options and treatment modalities. And as I speak about them, I don't want you to think about these as independent. Many times people will have one or more of these treatment options put together as part of an overall plan. So detoxification is usually an inpatient medical detox that requires monitoring and medication to help with withdrawal symptoms. So we see this most commonly with opioids, alcohol, and benzodiazepines, because if someone just stops taking them, they could become very, very ill. There's some detoxification programs that can happen at home, but most safe detox plans involve some kind of ongoing monitoring. After detoxification, many people will move toward a residential treatment, which can be somewhere between 10 to 45 to sometimes even 6 months of residential intensive treatment. And then to a less intense program like a PHP, where there are 5 days a week of maybe up to 6 hours a day of group therapy and some psychiatry management, to intensive outpatient, and then finally outpatient. And so a typical program might include detoxification, residential, and then either PHP or IOP, and then maybe ongoing psychotherapy at the end. But people often will do parts of these, may move back and forth. Sometimes people don't complete a residential, but they may go right into outpatient. So there's no one way, and each person is different in terms of what kind of treatment they may get. And then treatment models, and there are many others, but these are the main ones. Motivational interviewing, which I'm going to talk about at the end today, talking about helping people with their ambivalence and really developing change through ongoing self-efficacy. Cognitive behavioral therapy, working on creating more positive thoughts and targeting underlying beliefs that cause people to want to use. DBT, working on self-soothing and other skills that help people when they're having difficult emotions. And then 12-step models, core principles of abstinence using peer-led groups like AA or NA. And then finally, in the last decade or more, we have medication-assisted treatment, specifically for opioids and alcohol use. I'm going to be talking about medication-assisted treatments in another webinar, more specifically around MAT and TBI. But for our purposes today, you can see some of the medications that can assist in helping decrease use or cravings or withdrawal. So now we're going to talk about the intersection between brain injury and substance use disorders and specific indications and treatment considerations. I'm going to be talking about a case today. In this case, this is not a real person, but a conglomeration of several cases of someone who has a brain injury and also has a substance use disorder and some specific treatment interventions that have been effective. So in this case, Donna is a 48-year-old divorced female. She sustained a traumatic brain injury from a fall when she was intoxicated. She has significant long history of alcohol use and cocaine use. And after her fall, she had a moderate to severe brain injury. She developed seizures. Her motor skills were largely intact. Like, she is able to walk and move. She didn't require like a wheelchair or any assistive devices, but she has significant memory issues. She has undergone rehabilitation, including inpatient neurobehavioral brain injury treatment. And also she has gone to a PHP, partial hospitalization for substance use. She's currently getting one-to-one individual counseling, and she has an NA group and NA sponsor. So she's in ongoing treatment. So we'll talk about Donna on and off over the next several slides. So what comes first, TBI or substance misuse? So in Donna's case, she actually was using prior to her TBI, and in fact, the use of the substances caused her brain injury. But for other people, it can go the other way, where someone may have had a brain injury and then started to use substances. Maybe they were prescribed opioids while they were in the hospital, or maybe they are depressed and start using substances to cope with depression. So these two disorders have a complicated relationship. A history of TBI can relate to increased use. And we know that with one TBI, there's more increased severity, earlier age of first use after a TBI, and a higher likelihood of other psychological disorders. Children with TBI before age 5 are more likely to develop a substance use disorder. Parental and childhood alcohol use increases the risk of having a TBI. So here's the other side, right? So TBI increases risk, and use of substances increases risk of TBI. Overall, and this part is the most important part probably of the whole webinar today, is that having a TBI and a co-occurring substance misuse disorder is associated with poorer functioning overall, including higher rates of re-injury or having a second or third TBI, a suicide attempt or suicide attempts, decreased life satisfaction. And so that's really important, because when we're thinking about a person and their treatment, we can't just treat the TBI, right? We want to make sure that we're looking at, if someone has a co-occurring substance use, that we are really paying attention to the impact that's having, because it can create a lot of difficulty in rehabilitation and even can be life-threatening. So let's look at some prevalence and statistics with substance abuse and TBI. So about 50 to 67% of survivors with brain injury have had a pre-morbid history of substance use. And so these are folks that have been in a brain injury rehabilitation center. So these are people that usually have had a moderate or severe TBI. We're not including mild cases of just ED visits. We're talking about folks that are in rehabilitation. Alcohol is involved in about 2/3 of motor vehicle accidents in general, and 60% of the assaults that have resulted in TBI, right? So again, huge numbers. Research has found that misuse decreases immediately following an injury, but then increases after 2 years. So what does that mean? If someone had an injury, maybe they're in a rehabilitation center for 2 years and they may not have any access to substances, but once they get into the community and they're back into their normal life and they're exposed again to stressors and family, et cetera, the use actually increases. So we actually want to really target our clients that have been in the community ongoing as a potential substance use population, right? We don't want to just look at someone stopped drinking in the hospital, so they should be fine. We know that the research actually shows they're more at risk and more vulnerable when they return into the community. So approximately 10 to 20% of people who had no history of substance use are more vulnerable to having a substance use disorder after the injury. So again, what comes first? They are interrelated, and we want to assess and monitor and treat both, right? We want to assume that there's going to be a relationship between the two, and we want to make sure that we're regularly screening, assessing, and talking to our clients. Then we think about use and how it can affect the brain. So all of these substances affect the brain. In fact, when we think about addiction, we're talking about how the reward center of the brain and other parts of the brain are impacted. So if we look at alcohol, we know it affects memory, executive functioning, visual spatial abilities, motor skills. Cannabis can affect memory and executive functioning. Methamphetamines can affect executive functioning and memory. Cocaine can affect reward center, sensitivity to pain, executive functioning. Opioids, sensitive to memory, sensitivity to pain, executive functioning. So people that have had brain injuries who already have weaknesses in areas of the brain that are impacted by these substances can have a much more dramatic effect in a negative way when they take in substances. very simple. So if you think about Donna, when Donna had a relapse of alcohol, she actually had a seizure. She had a second TBI because she had a fall as a result, and her cognition was impacted. So she has her initial fall, and then it increases with a second fall. She has more cognitive issues, right? So the substance itself can create cognitive effects, and the risk for additional injuries, falls, motor vehicle accidents, etc., can happen. So in general, people who use substances after TBI have poorer recovery outcomes. Just really important to know. Substances affect the brain differently when someone's had a brain injury, and it can create a more powerful and dangerous effect. Substance use can increase depression and anxiety resulting from brain injury. Folks that have had brain injuries already are more likely to have depression. About 50% of people that have had brain injuries have some risk of depression and anxiety. Increased risk of seizure. In Donna's case, she had a seizure when she reintroduced alcohol into her system. The probability of enduring subsequent brain injuries, and there's a stigma, right? And so there are some treatment facilities that won't take people that have had brain injuries or have cognitive issues because they feel they won't understand the information or they're not good rehab candidates. And so it's harder to receive treatment if you have a TBI and a substance use disorder. There's more stigma attached to it. And then that cycle of addiction and higher risk behaviors and potential more brain injury damage can occur. So road to recovery, right? So how are we going to work with this group? It's really important to look at both the intersection of mental health, brain injury, and substance use when we're thinking about the path to recovery. So the Brain Injury Association of America put together this quadrant, which I think can be helpful, thinking about how to work with misuse in people with traumatic brain injury. So if we look over here, we see the substance disorder from a low severity to a high severity, and then the TBI from low severity to high severity. So if we think about folks in the lower mild brain injury category, when someone has a low substance use risk and a low severity risk, they're going to be screened. Essentially, they may be screened by their primary care provider, their psychologist. They may do some of those screening tools that I shared earlier in the presentation to see, is there in fact problem use and how significant is it? If someone is already coming in with significant substance use and they have a TBI, that's when we begin to think about accommodating so that they may benefit from treatment, but there may need to be some accommodations for them in treatment because they may have some limitations in their ability to remember information or process information. And so if they're going to be in an AA group, or if they're going to do some one-to-one or IOP, there may be some linkage with the leaders of the group to help accommodate and make sure the person's understanding the information. Someone with a high severity of TBI and high and low severity of substance use may get a little bit of education, right? So while they're in TBI rehabilitation, they may get some education and training and warning signs and some brief skills-based ways to cope with potential use issues, right? So it might be more of an educational service. And then finally, quadrant 4, and this is really where we see the most challenge. And Donna, again, falls into this category. She required special TBI services because she had a moderate to severe brain injury, and she had high usage. So she needs very comprehensive substance use services. So it needs to be integrated. In these other domains, we're seeing more education, screening, but we're not talking about equal integration. But in quadrant 4, for people like Donna, we want to make sure that they're getting equal intensive rehabilitation in both TBI and substance use. Okay, so challenges. So here we know, okay, someone like Donna, we want to give her really good integrated programming. But what if Donna isn't ready for integrated programming? Or what if she wants to continue to use, which is in fact what happened in her early treatment? Even with getting quadrant 4 treatment, integrated programming, she still used. So we think about, most people want to improve their health. And when I asked Donna, do you want to quit? She said yes. it's killing me. She was able to really articulate the problem, but she often felt ashamed. She felt like she didn't know how to do it differently. She's like, this is all I know when I'm depressed. This is what I reach for. And she also felt like she didn't have a lot of control. Change requires this ability to believe that I can control what's happening inside of me. That's what we call an internal locus of control, meaning that I can change and make a change in my life. People that have an internal locus of control tend to do better in treatment facilities. When people feel like it's up to other people, like, well, my mom made me do this. And that's what Donna sometimes would say too. She'd say, my mom made me go to treatment and I never wanted to go to treatment. I didn't want to stop using. That external feeling that like, it's not up to me, it's other people telling me what to do, that can often get in the way of truly believing one can change. So change can be very, very challenging. And we also are talking about a brain that is addicted to substances and rewired, so to speak. So we're talking about both physiological and psychological barriers to change. So if we're using the stage of change model, we're thinking about pre-contemplation, where a client doesn't see a problem, but they know other people disapprove. Like in Donna's case, she said, oh, my mom hates that I use. She's always been on me for using. Okay, so but I don't think it's a problem. To contemplation, like I know I should stop, but I don't want to, or it's too hard, or I don't have any control. To I'm gonna stop using, this is how I might do it. To then actually putting those practices into a daily lifestyle, and then maintenance. And we see that many people relapse with substance use, and the cycle can take quite a while for optimal change to happen. But most people are somewhere in this process of change. And with Donna, after her relapse, which she had a significant relapse, she ended up going right back really into active change. She knew she needed to stop using. So sometimes people don't have to go through all of those cycles over and over again. They may be able to put into play some of the things they already learned the first time around, or the second time, or the third time. So it's important to recognize change as this ongoing active process. Here's some other ways to think about the stages of change. And now we're going to start to look at interventions here. So when someone's in pre-contemplation, like Donna was initially, we're not going to talk to her about you have to stop, but more about like, what would it take for you to consider seeking help? Or maybe giving her some of the dangers or risks of substance use and TBI, which is what we did. Talked about how it increased her risk of seizures and falls. When someone already recognizes and thinking about change, we can begin to talk about the benefits, emphasizing how good the person might feel after they have been able to stop. And then trying to get them to commit to some action steps. What would it take for you to seek help now? Preparation is referring to someone who's ready to take change within the next 30 days. And we start to discuss strategies and options like, okay, and so in Donna's case, it was, are you willing to find a sponsor when you go to your first NA meeting? So we talked about some strategies. And in fact, for her, she really liked the idea of having a sponsor. And she said, I really want someone who's going to hold me accountable, that I can call and that will answer my phone calls in the middle of the night. So that was part of her preparation, was I'm going to go to an NA meeting and I'm going to see if someone would be a sponsor. And then an action plan is to actually start and maintain the behavior. What do you think is the biggest challenge? In Donna's case, it was, she said, getting lazy, not wanting to go to my meetings. And how might you deal with that? She said, I need people to encourage me to go. I need my family to go to my meetings with me sometimes. And then maintenance, looking at what are the emotions or people or place that might create a desire to use. And for her, when her father passed away, she was really at risk. But because she had done so much work, she was able to get additional support. She met with her sponsor. She increased the amount of meetings she went to. And this really helped her stay in a maintenance phase. So motivational interviewing can be very helpful when people are in different stages of change, particularly in the ambivalence and preparation stages. So MI, motivational interviewing, was created by two psychologists, Miller and Rolnick, in the early 2000s, in the early 1980s, and then expanded into the 90s and 2000s, looking at problem behaviors in general. And it's really looking at how to help someone's own motivation. As I said earlier, when people believe that it's up to other people or other people are making them try to stop using, it doesn't work. So MI really focuses on how can we help a person find their own motivation. In Donna's case, how can we get Donna to create her own sense that she can change her behavior and that she can create her own plan, that it's not up to her mom or her therapist or her providers, it's up to her. And when we were able to get to that place, that's when she succeeded in her recovery, when she said, it's up to me and this is what I need. So we want to help by being collaborative, first of all, really partnering with the client, helping the client find their own resources, and honoring autonomy, helping the client to make their own choices. And this is really important, especially for clients with brain injury who tend to feel that they don't have a lot of autonomy. Donna would complain all the time. I had staff with me, I had people telling me what to do. So she didn't feel like she had a lot of autonomy. And when she was able to make decision after decision, when she had more and more choices, you could see her ability to believe that she could help herself increase and improve over time. So it's really important to help a client honor what is inside of them and feel like they can control their own life. And so these are some of the principles. And it's hard to do that. We want to not overly try to persuade. Donna had many people in her life trying to get her to stop drinking or stop using. And she would get so angry. She'd say, I don't want to hear it. She'd yell. So we want to listen rather than try to create a kind of you should attitude, right? The righting reflex. To really hear what is most important to you, what matters most, what would help you, to listen empathically. That quote from Edgar Allan Poe about how much suffering the person was going through. Really, we want to hear their story and we want them to feel our care, because that can make a big difference. When a client feels that we care about them and our care can make them feel understood and valued, that can help empower them to make positive decisions. And then we want to ask questions. So much of motivational interviewing and helping clients in early stages of recovery is helping them think about what would help me, what would help, and why do I use still, right? How important. So we have something called a readiness ruler in MI, which is looking at what would help you increase your readiness, what would help you decrease your use, right? It's not telling them to do it. It's getting them to think about what matters to them, right? And Donna was able to say what helped her decrease her use was feeling like she had more choices. Also, what helped her feel more ready is she wanted to go back to work. She wanted more independence and realized if she used, she was setting herself back. So asking questions without telling the person what to do can be very helpful. So here are some considerations with substance abuse and TBI treatment. And SAMHSA has this lovely toolkit which looks at how to introduce the model of intervention with someone with a traumatic brain injury. So number one is you want to help the person understand what substance use and brain injury treatment looks like and what the client's rights are. We want to help them understand what it looks like. And then we want to really help the person focus on what is their vision for the future. So many clients with traumatic brain injury feel like their future is irrevocably changed, that they'll never get what they wanted, their life is ruined. We want to start thinking more proactively. What is their vision for the future? How do they want to live? What would be a way to take a step toward that future, to live a happy life, a good enough life, a life worth living, a life with meaning? And then you can see the stages of change here, helping the client prepare for change, start to make steps, gather resources, who can do it. So we know with our clients, we may have to help them see, oh, this person in the community works with people that have had brain injuries, or this clinic has an outpatient depression and substance use treatment that might be beneficial. So looking at what are the resources, taking action, how do I prevent the problem situation from happening again? In Donna's case, it was like calling her sponsor. It was doing her soothing, which was involving taking a warm bath. She liked to bake, right? So it's doing coping skills. And finally, what helps to maintain the goals. So the stages of change are the same, where a person really moves through and does a lot of pre-planning even before the treatment begins. And with traumatic brain injury, we may need additional help at each stage to help a person come up with the different levels of intervention that they need for each stage. And for the providers, this is the second part, which is building an alliance. That's the number one thing. When we're working with someone who has a complicated brain injury, mental health, and substance use combination, we want to first have them feel like they can trust us and create a safe environment. Many clients with substance use and TBIs have grown up or have been in unsafe environments where they don't feel like they can trust. Once we have that trust and that alliance, we can begin to enhance motivation using motivational interviewing, looking for change, stage of change, talk, goal setting. And then again, we're moving through by setting goals, skill building, and creating a relapse prevention plan. So the models are similar, substance use and TBI treatment combined, but we may need to do some specific interventions. So I'm going to go over these next. So if you are working with someone with a brain injury or who has cognitive limitations, number one, we may need to modify information. So if we're going to go through, let's talk about 12 steps. We might not go through all 12 steps if we're doing a 12-step program. We might focus on step one for 6 months, right? We want to really modify material to make it simple and to the point. We want to use concrete examples. I've had clients go to AA and NA, and this is just an example. It's not like AA or NA do it better or worse than anyone else, but when they talk about a higher power, some clients with brain injuries may not understand that language, something that's abstract. So we want to be concrete. It's really helpful to write things down. It's helpful. It allows the client to really think about what matters most to them, and it helps them remember, because it's so frustrating to not remember information that might help them in their recovery. I always encourage clients to bring something to write information down if they're going to a group or an individual session. We want to write down homework assignments, and then meeting individually with clients if they're in a group setting is really helpful. I will often ask what stuck out for you, or what matters, or what's a take-home point? And if they don't have one, I might help them remember which of the activities we did and see if that helps them decide. Helping friends and family. So sometimes friends or family can go to a meeting or might help and meet with a clinician to reinforce the goals. And don't take for granted that learning has happened or that it can be generalized. Sometimes we have to really go over things and imagine, okay, practicing in this situation. Now you're going to a family event where there's alcohol. What would you do then? So repeating, rehearsing, and reviewing, really important. And sometimes people with substance use disorders and TBIs have inappropriate behaviors in groups, right? Because maybe they're more impulsive, or maybe they have difficulty taking turns, or maybe their speech is difficult to understand, so they get frustrated. So what do we do in that situation? So number one, we want to be very concrete and let someone know that behavior is not acceptable in the group. We might say something very calm, like in this group, we use polite language. In this group, we use a low voice. Very straightforward, not shaming, not criticizing, but expecting group appropriate behavior. If someone gets very tangential or excessive, there's different ways to navigate. I may say to the group ahead of time, I may stop you if we need to get to something else, and I really want to hear you, and we'll talk after the group, but a way to make sure that someone doesn't monopolize. Really being careful with motivation, especially with clients with brain injury who have frontal lobe issues. Their ability to initiate and remember information is impacted. And so if they don't come to group, if they forget to do something, if they don't call their sponsor, that doesn't mean that they don't want to do treatment or they're not motivated. So non-compliance or an unaware of deficits may be a result of the brain injury, not psychological resistance or a stage of change readiness problem. So we want to really be overly generous in how we're viewing people with brain injury and substance use, not to infer that it means that they're not invested in treatment. Confrontation, whether it is due to the brain injury or whether it is due to resistance, shuts people down anyway. So we want to make sure that we have very generous views of compliance, of follow-up, and just keep working with people if they haven't shown progress or they're missing appointments, to keep giving people more opportunities, because often there are multifactorial reasons why someone may not be progressing in treatment. There are many clients that benefit more from one-on-one. So sometimes group settings may not be the right setting as well, because there's too much stimulation or they have personality and behavioral challenges. So also being flexible in what approach works best, right? So for some people, one-on-ones, for some people, peer support is more effective, particularly if they have challenges with people in authority or they really struggle with that internal and external control. So we want to find out what works best for this person, and we can ask them that. So that is an overview of substance use and brain injury and some considerations for treatment. In future webinars, we're going to be talking about medication-assisted treatment, and look forward to seeing you in future webinars. Thank you so much for participating today.